I'm a professor at the University of Birmingham and a consultant at the Birmingham Community Healthcare Trust Dental Hospital. And I've been asked to speak about comorbidity. I've chosen the title because I wanted to grab your attention. And now I'm going to explain to you the rationale behind the choice of the title. If you haven't been to the dental hospital, this is the view from the top floor. It's pretty impressive. Come and visit. And our infection prevention is meticulous, believe me. So some of you that aren't obviously working in the oral health care field probably won't know what periodontitis is. It's basically severe gum disease. And to put this into perspective, oral diseases are the most prevalent diseases of human beings. And the Lancet Global Burden of Disease study in 2017 made it very, very clear that more years are lost to disability from oral diseases than from any other 364 human diseases. So it's a big problem. And the cost of periodontitis is 80 billion, as you can see there. It's huge. Perhaps more importantly, it impacts in a mild form up to 45–50% of the population. But about 11% have very severe disease, which is the disease I'm going to focus on today. The latest World Health Organization data has increased that to 19%. And it causes tooth loss, negative impacts on speech, nutrition, quality of life, and overall well-being. And it is also a significant and independent risk factor for mortality from any cause or for cardiovascular mortality. And so as a result of that, the World Health Organization have only just in the last few months produced their first ever oral health strategy. And so what I plan to cover is a little bit of an introduction to non-communicable diseases, because periodontitis is an example of a non-communicable disease. I'm going to take you through, with a cartoon, the pathogenesis of the disease, how it develops, because that's important in trying to explain the links with heart disease, particularly atherogenic cardiovascular disease, and also with type 2 diabetes. And then I'm going to use videos, some short video animations to explain those pathogenic links, because it's better for you to visualize it than it is for me to talk about it. So that's the plan. We're all getting older, sadly. You're a day older than you were this time yesterday. And there's not a lot you can do about it. It is genetically determined, but there is something you can actually do about it. The rate at which we age is governed by our lifestyle and our environment. So we do have a degree of control over that, in particular when we think about exercise, when we think about habits such as smoking, etc. So it's one thing to have a genetic predisposition to a non-communicable disease, but the translation of that genetic predisposition depends upon our lifestyles. And if you don't understand that, we'll have a chat over lunch, and I'll explain, or give your mum a ring tonight. So non-communicable diseases are the biggest cause of death, of mortality in the world, 38 million people, and 16 million of those deaths are premature. That's defined as under 70 years of age. They're increasing in prevalence, and they're associated with sedentary lifestyles, refined carbohydrate diets, etc. And over 90% of elders have one non-communicable disease, and close to 80% have two or more. And that's obviously what we term comorbidity. And 60% of older people have periodontitis, have severe gum disease as such. And it's the sixth most common human disease on its own. So there is a lot of data to demonstrate that periodontitis is independently associated with premature mortality. And these are studies from America, from Northern Ireland, Finland, Sweden. There are loads of these studies, including from Birmingham, a study we conducted in Birmingham that shows exactly the same type of data. The index study is the Raul Garcia study in Boston, started in the early 60s. They now have 50-year data. And these patients are medically phenotyped, they're dentally phenotyped, and if you have moderate or severe bone loss around your teeth due to periodontitis, your risk of mortality is increased by 85%, okay? And that's independently of other risk factors. So the question is why? And the answer lies in what these conditions really all have in common. What these conditions have in common are, well, does anybody know? Anybody care to guess what these conditions have in common? Inflammation. They're all inflammatory diseases. The majority of non-communicable diseases of aging have inflammation at their source, if you like. They're all complex diseases. They don't have a single cause. There are multiple component causes or risk factors that drive the expression of the disease. They're all independently associated with periodontitis, and they're all non-communicable diseases. And this image here showing the teeth and the jaws, you can see where the black spaces are. That's where the bone should be, but it's where the bone has disappeared. So it's quite a destructive disease, very similar, if you like, to rheumatoid arthritis in the way it sort of presents. And complex diseases, as I say, have more than one cause. And just to explain this, a very famous epidemiologist, Rothman, essentially proposed this causal pie theory for complex diseases. So this applies to cardiovascular disease, to COPD, to rheumatoid arthritis, whatever chronic kidney disease, whatever non-communicable disease you talk about, this model applies. Each one of these represents a patient. And if these are patients with periodontitis, you have to have a full pie for the disease to express. So all the slices have to be there. But you'll note in patient 1, they have D as a slice. That's probably something like smoking. Here they have G as a slice. That's probably a high refined carb diet. I in this patient may be stress without coping behaviors. And so this gives huge heterogeneity. You've got multiple different component causes, and they're different from one patient to the next. There's one exception, and that is slice A, and that is a necessary prerequisite. You don't get the disease without it. We used to say this was a buildup of dental plaque on the teeth and around the gum margins. In fact, today I would say this is inflammation, okay, because one causes the other, and the other causes the other. They're sort of in a circular relationship. If your gums are inflamed, more plaque builds up. If the plaque builds up, it drives more inflammation. And that inflammation then spills over into the rest of the body. And I'll show you how in a minute. So this is a cartoon, and for those of you that are not dentally orientated, what this shows you is this is the edge of your gum. If you put your fingernail above the edge of the gum, you're touching this bit here. And there's a natural space between the gum and the tooth. It's called the gingival crevice, okay? And it's unique because this is like a bone, a compound fracture of bone. It's like a bone sticking out through your skin, and you've got 28 of them. And the plaque here that builds up, this is the second most complex microbiome in the body after the gut microbiome. So you have exposed internalized structures to a shed load of bacteria. And in health, the bugs are good bugs. They promote health. They live symbiotically with our immune system. But if you don't clean the plaque off the teeth, because if you think about it, your skin sheds, doesn't it? So when the bugs build up on your skin, every few days it sheds. Your enamel doesn't shed. At least I hope it doesn't. So you have to physically remove the bugs. And if you don't remove the bugs, they irritate the lining epithelium here, which is under the gum, between the gum and the tooth. And that sends alarm signals into the underlying connective tissues. And we get an inflammatory response developing. And we call that gingivitis, which is very, very mild gum disease. 9% of the population have it. It's reversible. If you remove the biofilm, or at least break it down and disrupt it, then it will reverse. But there are a group of patients in whom the inflammation becomes uncontrolled. It's exaggerated, it's too strong, it's not well directed. And that inflammation destroys the bone that holds the teeth in the jaws. Okay? So it's kind of an autoimmune disease, if you think about it that way. Again, similar to arthritis. Now, what happens when the inflammation builds up is you get various oxygen radicals and enzymes released that break down the adhesion molecules between the epithelial cells. When that happens, these little holes develop. If you think of a tea bag with little perforations, these are microscopic ulcers. And those microscopic ulcers allow the blood to flow from the tissues into saliva. So when you brush your teeth and you get blood in your saliva, you've got some gum disease, and that's not normal. But equally, they allow the bugs to get into the bloodstream and into the circulation every time you eat, every time you talk, every time you brush your teeth. You get a bacteremia, a transient bacteremia. And so what on the face of it may look like a relatively healthy mouth, I know our dental nurses at the back are looking at it thinking, now that's not healthy. I can see the inflammation around the margins. If you look under the surface, that's the patient I showed you earlier on. Massive bone destruction beneath the surface, hidden unless you examine the patient carefully. So how does the gum disease link to mortality? How does it link to these other non-communicable diseases? And there are a number of mechanisms that have been proven. And the first one we call disseminating oral infection. When those bugs enter the bloodstream through those ulcers, they fire off an acute phase response in the liver. So your CRP levels go up. When your CRP levels go up, inflammation in the body goes up, big risk factor for cardiovascular disease. The other thing that the bugs do is they activate neutrophils in the bloodstream, and they start firing off and releasing oxygen radicals within the bloodstream that can damage blood vessels. The other thing that can happen is the inflammation can spill over from the oral tissues into the bloodstream. And that's been shown in a number of studies now. And then the final one, I call it immunological memory. Basically, what this means is the inflammation causes post-translational changes to proteins within the oral tissues, and it creates autoantigens. You get massive citrullination from this inflammation. And if you're wondering what that is, it's the production of citrulline, an amino acid, that is autoimmunogenic, and the antibodies to the citrullinated proteins, or ACPAs, are diagnostic of rheumatoid arthritis. Those are the antibodies that cause rheumatoid arthritis. So there are many different links with many different systemic diseases and different mechanisms, but I'm going to focus largely on the disseminating infection and on the inflammation. I'm not going to talk about rheumatoid arthritis because that would probably take me about 3 hours, but suffice to say, it is very similar, it is strongly associated with periodontitis, and the type of joint collapse and bone erosions you get in rheumatoid arthritis are very similar to the picture I showed you of the bone around the teeth in the jaws. So a number of years ago, there was a systematic review undertaken by this guy, 2016, looking at how many systemic conditions had been investigated in terms of their association with periodontitis, and there were 57, including male infertility. And I must admit, when I read that study on 350,000 guys, I thought, this is rubbish. This cannot be true. But what is interesting is when you look at male infertility and the risk factors, or those slices in the pie, the component cause, the biggest risk factor is inflammation. And we know that periodontitis causes inflammation in the body in general. So it kind of started to make sense. Biological plausibility is what there was. And back in 2014, the editor of the British Medical Journal asked me to write an editorial on this association because he was very aware of it, but he said the medical community are very unaware of it, and I want you to educate them. So I wrote the editorial, and it had zero impact. Completely failed, for reasons I'll go into. So we then had a workshop with the International Diabetes Federation, so the leading endocrinology specialists that focus on diabetes, because they were very aware of the association. And we produced some guidance and recommendations published in the Diabetes Research and Clinical Practice Journal and in an oral health journal as well, simultaneously. We did the same with the World Heart Federation in 2019. So the World Heart Federation looked at all the literature with us, we did systematic reviews, and we produced recommendations on cardiovascular disease, again jointly published in Global Heart and also in an oral health journal. It still had no effect. And it had no effect because it's one thing for a load of specialists to sit down and pontificate and produce a load of guidance, but if you don't gather information out to where the bulk of the work's done, which is in family practices, family doctors, and you don't get the message out into the primary care sector and to the public, then you've failed. And that's why we failed. So we then worked with The Economist, and this was published just over a year ago, and it was a white paper by The Economist that basically did economic modelling on the cost of severe gum disease to the economy and also to patients. And it was quite dramatic, the data, and governments have started paying attention to this, and healthcare funders have started paying attention to that white paper. But the next thing we needed to do was to reach those family doctors, so we then had a workshop last year with the Wonka Group. Sounds like a Roald Dahl character, doesn't it? It stands for World Organization of National Colleges and Associations. It's written down there, it's huge. It's basically the academic leadership of family doctors from across the world. And so we got together and we looked at 3 different types of association. We looked at cardiovascular disease and periodontitis, we looked at diabetes and periodontitis, and we looked at respiratory diseases and periodontitis. And I chaired the diabetes one. Some of the medics were there in person, some dialed in. And we produced recommendations, which I'll share with you shortly. And that was published literally just last month, I think, or a couple of months ago. And we hope that is going to have an impact. So people often say, well, why should periodontitis be associated with mortality and with these non-communicable diseases? And there are a couple of hypotheses. The first one is this genetic or lifestyle predisposition to being hyperinflammatory, producing too much inflammation. And there's no doubt that there are a group of the population that are hyperinflammatory. And as a result of that, therefore, they're predisposed to rheumatoid arthritis, atherogenic cardiovascular disease, various respiratory diseases, etc., and periodontitis, because they're all inflammatory diseases. And so the association between periodontitis and these other non-communicable diseases is chance. It's just the fact that we have a bad lifestyle and we have this genetic predisposition. That's one theory, and there is some evidence for that. And the World Health Organization are really focused on all healthcare teams providing basic advice in smoking cessation, which we do all the time. We do it because they're risk factors for periodontitis, but there's a collateral benefit to these other inflammatory diseases of dental teams getting involved in that. The other hypothesis is one that I refer to as co-morbidity and cumulative damage. And to explain this to you, I'm going to take a cohort of patients with chronic kidney disease. This is a study that we did, Praveen Sharma's one of my team, looking at patients with CKD. And this is over 13,500 patients. And what this graph shows you on the y-axis is survival, and on the x-axis is time in years, 10 to 15 years, basically. And if you have chronic kidney disease, then your mortality increases by 32% from any cause over 10 years. And your cardiovascular mortality increases by 16%. If you have periodontitis as well as CKD, then you get a further increase in 10-year mortality of just under 10% and in cardiovascular mortality of 6%, which doesn't sound like a lot. But if I replace the red line, periodontitis, with diabetes, then they almost superimpose. So the impact of periodontitis is as strong as diabetes on mortality. But sadly, many of these patients have all three. They're multi-morbid, and therefore very few are left alive at the end of 15 years. Now, I always do this just to create a little bit of a murmur amongst the audience. Hands up those that are over the age of 40. Don't be shy. Right, you're all in kidney failure. So our kidneys start failing about the age of 40. But it's a slow process, so don't worry about it. You'll die from something else. You'll die from something else. Just drink lots of water. So we've got a cohort in Birmingham that we established. It's a comorbid cohort of patients with CKD, chronic kidney disease, just under 800, and we've followed them almost for 10 years now. And they are high-risk CKD of end-stage renal disease. They're at stage 3 to 5 chronic kidney disease. What we've done is we've measured their kidney function using an estimated glomerular filtration rate, and we've measured their vascular stiffness, their cardiovascular risk, using pulse wave velocity. But look at the prevalence of periodontitis. It's 81% in this population. And if you consider 15% have got no teeth, and most of them will be edentulous because of the gum disease being really severe, you've got well over 95% of this population, more than twice the community-dwelling adult population of most countries in the world have periodontitis, or have had it. So what we've done is we've looked at the relationship between the periodontitis and kidney function, and you can see that this is periodontitis on the right. We've looked at lots of different measures. This is the size of the pocket, the space between the gum and the tooth, and the deeper, the more severe the disease. And there's a significant relationship with a lower kidney function. And then when you look at vascular stiffness again, then pulse wave velocity, basically the quicker the pulse goes, the stiffer the arteries. And this relationship here shows you, again, a very significant independent relationship between severe gum disease, periodontitis, and vascular stiffness. So when you then look at this data, you ask yourself the question, well, is there a causal relationship? Could periodontitis be one of those slices in the pie for cardiovascular disease? And to answer that question takes decades. You start off with big epidemiological studies that look to see if the two conditions are related. You then ask, well, does it make sense biologically? Can you explain mechanisms? Then you go into observing people who don't have the periodontitis, who don't have the diabetes or the heart disease or the kidney disease, but do have periodontitis. Some do, some don't. And you see if those with the periodontitis are more likely to develop the heart disease. And then you intervene and you treat the periodontitis and see if you improve the cardiovascular outcomes or the diabetes outcomes. Can we crank the volume up a little bit? This is a biological mechanism.
Infarction, a life-threatening clinical manifestation of a series of inflammatory changes in the walls of the coronary arteries. It is a leading cause of death in the Western world. Can periodontitis or other inflammatory processes of the oral cavity contribute to the development of cardiovascular diseases and systemic conditions such as atherosclerosis or diabetes, or negatively influence their course? In periodontitis, the presence of a bacterial biofilm on the root surface triggers an immune inflammatory response. Inflammatory cells infiltrate the connective tissue, and the pocket epithelium becomes ulcerated. The total wound area of connective tissue exposed to the subgingival biofilm can range from 5 square centimeters to 20 square centimeters, an area the size of the palm of the hand. Periodontal bacteria from the biofilm will repeatedly enter the blood vessels of the gingiva, for example when eating or brushing, due to this exposed connective tissue. Similarly, locally produced inflammatory mediators will shed into the bloodstream. From the local vessels, bacteria and inflammatory mediators will spread through the entire body, threatening the integrity of the vital internal organs and structures of the body. Periodontitis, therefore, is not just a local issue, but may have systemic effects even at distant locations away from the oral cavity.
So I've got a couple more of these. One I'm going to show you in relation to the association, the biological plausibility of periodontitis and heart disease, and then similarly for diabetes, because it's easier than me talking about it. I'm just going to very, very briefly summarize what the workshop with the World Heart Federation showed from all the literature, and that is that there is consistent and strong epidemiological evidence that periodontitis increases your risk of future atherogenic cardiovascular disease, and that the impacts are biologically plausible, and I'll show you the mechanisms in the next video in a bit more detail. And it's about the translocating bugs getting into the vasculature and then affecting the vascular endothelial cells. And there is now data from human studies that shows that if you treat periodontitis in somebody with heart disease, you improve their cardiovascular function. And the same actually applies for diabetes. These are the mechanisms.
Some bacteria, such as Porphyromonas gingivalis, have special structures on their surfaces, the so-called fimbriae. These fimbriae allow them to attach and penetrate the layer of endothelial cells lining the blood vessels. Well hidden from the immune system, the bacteria survive, persist, and multiply within the cells and infect other endothelial cells. Receptors such as TLR2 and TLR4 detect the bacteria. This results in activation of the endothelial cells with secretion of pro-inflammatory cytokines and chemokines such as monocyte chemotactic protein 1. In addition, vascular cell adhesion molecules and other cell adhesion proteins are expressed on their surface. This attracts monocytes, which then bind to the endothelial cells. Furthermore, signal cascades are induced inside the cell, ultimately leading to apoptosis in some of the infected endothelial cells. This is the early stage of atherosclerosis, endothelial dysfunction. Blood vessels begin to lose their elasticity. The next step in atherogenesis is the formation of so-called fatty streaks. Monocytes migrate into the vascular wall, differentiate into macrophages, and take up oxidized LDL cholesterol and turn into foam cells. Periodontal bacteria like P. gingivalis may promote the formation of fatty streaks by increasing monocyte migration, the oxidation of LDL, and the uptake of oxidized LDL by macrophages. The foam cells gradually become apoptotic, forming a necrotic core within the atherosclerotic plaque. Muscle cells of the lamina media proliferate and migrate into the intima, as well as T lymphocytes and other immune cells. This eventually leads to the formation of a mature atheroma that reduces the cross-section of the vessel, causing hypoperfusion and hypoxia of the tissues that the vessel serves. For example, the heart, if the coronary arteries are affected. Possible future complications can be actively exacerbated by the unique properties of periodontal pathogens, which promote the formation of matrix metalloproteinases by T lymphocytes and other cell types. These proteinases gradually degrade the connective tissue so that the atherosclerotic plaque is ultimately broken up. Platelets rapidly attach to the rupture sites, they mature and coagulate to form a thrombus. This further narrows the already reduced blood vessel lumen and may even lead to complete vascular occlusion. Clinical events, such as a myocardial infarction or a stroke, may occur as a result. The cytokines secreted by the dysfunctional endothelial cells act not only locally, but spread through the bloodstream to all other parts of the body. The bacteria in the blood and their lipopolysaccharides induce the formation of acute phase proteins, such as C-reactive protein or CRP in the liver. The messenger substances in turn cause a systemic inflammation that can promote all stages of atherogenesis.
Far better than I could have explained it to you anyhow. But you can see the process and how those bugs get into the bloodstream, and they have these unique properties to bind to the endothelial cells. Anybody know when atheroma can first be imaged in life? At what age? About 9 years of age. 9, 10 years of age, using modern PET scanning, that you can see the atheroma starting to form. So yeah, it's really quite shocking when you see it at that age. So what about diabetes? Diabetes obviously is a pandemic, and this is the United States of America, showing how serious the pandemic is. This is 1994, and if you watch the number at the top here, what this shows you is what changes with time. So this is the percentage of the adult population in each state that have type 2 diabetes. The cream is 4.5% roughly, or just below. The lighter yellow is 4.5 to 6%. We start running out of the lighter yellow in the early noughties. Then we get into the mid-coloured orange, which is 6 to 7.5%. And then we end up with the darker coloured orange, 7.5 to just under 9%. And then the red starts to kick in as we progress through. And I think this stops at 2013. It hasn't got any better since 2013. We now have 2/3 of states in the United States where adult diabetes rates are 10% or higher. So it's a huge problem. So from an epidemiological perspective, 52 million people in Europe also have diabetes. We're not much better than the USA. That's predicted to increase to 70 million by 2035, which is about 8% of the European adult population. 17 million undiagnosed cases in Europe. There's 1 million undiagnosed cases in the UK. And the cost is huge, as you can see here. And it's only going to increase. So this was the workshop with the International Diabetes Federation. And if you can't read this, you need to see an optician. Please don't try to read it. I can't read it, and I'm standing right next to it. It's just to make the point that we produce guidelines into 4 sets. The first set of guidelines are for physicians working in general medical practice. The second set of guidelines are for patients in the waiting room of their doctor's surgery. Third set of guidelines is for all healthcare professionals. And then the fourth set of guidelines is for patients sitting in the waiting room of a dental practice. So we've tried to target all 4 groups because we need to see much more joint working. So what do we know about the relationship? Well, we know that severe periodontitis is strongly associated with glycemia in non-diabetics. So if you measure HbA1c levels in non-diabetics, we know that there's a strong relationship, independent relationship, and a significant one with periodontitis. The same if you have diabetes. Severe periodontitis is associated with poorer glycemic control. And the relationship is bidirectional. The worse the diabetes, the worse the gum disease. And the worse the gum disease, the worse the diabetes. And severe periodontitis now has been shown in several studies to increase the likelihood of type 2 diabetes developing. Okay, and the reason that causal link I'll show you through the last video, which is actually now.
The systemic inflammation triggered by periodontitis can also affect the regulation of blood sugar. Normally, membrane-bound insulin receptors register the presence of insulin in the blood. When insulin binds to these receptors, a signaling cascade is initiated inside the cell, which ultimately activates glucose transporters. This allows the glucose that enters the bloodstream following a meal to enter the cell, where it is processed for energy or storage. In the presence of systemic inflammation, inflammatory mediators, oxygen radicals, and acute phase proteins interfere with this control mechanism. They inhibit the insulin receptors and reduce the uptake of glucose into the cell. Cytokines such as tumor necrosis factor alpha and interleukin-6, whose serum levels are significantly increased in periodontal infections, seem to play a special role here. The acute phase protein CRP induced by these mediators also appears to be of importance. In the presence of severe periodontitis, blood sugar levels can deteriorate over the years in a clinically significant manner, even without diabetes. There is a risk of developing a so-called insulin resistance. If diabetes is already present, the simultaneous presence of untreated severe periodontal disease makes proper glycemic control more challenging and increases the risk for complications of diabetes that affect the kidneys and heart many times over. Conversely, some disease mechanisms of diabetes can contribute to the deterioration of the patient's periodontal status. In particular, the Maillard reaction is relevant here. This reaction describes the non-enzymatic binding of sugar to protein molecules. For example, glucose in the blood binds to the hemoglobin of the erythrocytes. The percentage of glycated hemoglobin A1C, known as HbA1c, is an important diagnostic and monitoring tool in diabetes, reflecting the patient's blood sugar control over time. However, with persistent hyperglycemia, even other proteins are glycated and eventually converted to so-called advanced glycation end products, or AGEs. AGEs are irreversible and mediate pathophysiological mechanisms which promote in various ways the development and progression of periodontal disease in diabetes. For example, AGEs cross-link the collagen strands of connective tissue. The resulting thickening of the basal membranes and the inhibited degradation of extracellular matrix interfere with the physiological tissue repair and wound healing processes, including in the periodontium. Furthermore, AGEs are recognized by a signaling receptor correspondingly named RAGE. This receptor is present on many cells of the human organism, including monocytes and endothelial cells. When AGEs bind to RAGE, one of the results is the production of reactive oxygen species and of pro-inflammatory mediators. These reactive oxygen species and cytokines promote periodontal inflammation and ultimately exacerbate periodontal tissue destruction through an exaggerated inflammatory response and limited tissue repair.
So, about 3 more minutes. Intervention studies. Can we improve diabetes outcomes? The answer to that is yes. If periodontal treatment is done well, then you reduce HbA1c levels by somewhere between 0.3 and 1%. That's quite a big range, but it's the equivalent to a second drug in a metformin regime. So it's actually quite significant. You improve your dyslipidemia, your HDL levels go up, and your LDL levels go down. You reduce cardiovascular and renal complications, and if you do the treatment intensively, then this study published in the Lancet Endocrinology just a few years ago shows a reduction of 0.6% at 12 months in HbA1c. That is really clinically significant just by having the gum disease treated. And the effects are dose dependent. The better the periodontal outcomes, the better the diabetes outcomes. So what was the conclusion of the workshop and why did we do it? Well, the reason we did the workshop with the family doctors was because of this huge number of 22 million undiagnosed cases in Europe. And they're walking into the surgeries of oral healthcare professionals. So the oral healthcare professionals have an opportunity to risk assess for diabetes and to refer on to a family doctor for formal diagnosis. It's also important for family doctors and nurses within practices to be able to identify if diabetes patients have gum disease problems, because if you treat the gum disease, the glycemic control improves. It's a two-way thing. And we need to develop methods to do that, and we're working on that at the moment in terms of a simple saliva lateral flow test that will identify whether somebody has severe periodontal disease or not. We've already got the markers, and we're just trying to adapt them to the lateral flow technology at the moment. And then the referral can go in the other direction from the family doctors to the oral healthcare professionals. One of the key outcomes, and I get this every time I talk about diabetes at the Olympia Diabetes conference they have every year, somebody in the audience will always say, well, if I have diabetes, I get free eye tests and I get free podiatry and tests. Why don't I get free oral health tests, a free dental test? And it's a really, really good point. And there's a very simple reason, because it costs money and the government aren't prepared to pay for it. And not just this government, every government for the last goodness knows how many years. And that was a clear statement that's come out from this workshop, that governments need to be providing free oral health care checks for people with diabetes. So, I've just buzzed on 40 minutes. We're done. My concluding slide. Periodontitis is independently associated with all-cause and cardiovascular mortality. And the mechanisms I've shown you are about disseminating infection and disseminating inflammation from the gums into the bloodstream. And periodontal treatment can improve outcomes in diabetes, in cardiovascular disease, and we've just published a study last month that shows that the number of inflamed and painful joints and the disease activity, the DAS28 score in rheumatoid arthritis patients, also improves dramatically if you treat their periodontitis. So I hope you found that interesting. You're all going to go home and spend twice as long cleaning your teeth now, aren't you? Yeah. Thank you for listening.